I'm Dr. Adrienne LaBailey, the Public Health Director for the Larimer County Department of Health and Environment, and I'm delighted to welcome you today to this very important presentation. Dr. Robert Belknap is Director of the Denver Metro Tuberculosis Control Program, which provides TB treatment and control services for Adams, Arapahoe, Boulder, Broomfield, Denver, Douglas, and Jefferson counties. He's worked as an infectious disease specialist for Denver Public Health for over a decade and is also assistant professor of medicine in the Division of Infectious Diseases at UC Denver. Dr. Belknap graduated with highest honors from Kent State University, attended medical school at The Ohio State University College of Medicine, and did his internal medicine residency and ID fellowship at the University of Colorado Health Sciences Center. He has been principal investigator on numerous TB-related research projects and authored many publications and given many TB-related presentations, including as invited moderator and speaker for a briefing on tuberculosis before the United States Senate. For over 15 years, he has been an instructor of the National Jewish TB course, one of the premier continuing education courses on tuberculosis in the country. Through the Larimer County Health Department's contract with the State TB Control Program, we have access to Dr. Belknap's outstanding expertise in TB control whenever we face difficult or complicated cases. Either he or his colleague, Dr. Michelle Haas, reviews every chest x-ray that is suspicious for TB for public health agencies throughout the state. He is unfailingly helpful to us with difficult cases, and given all his responsibilities, is amazingly accessible for consultation. His passion for putting an end to tuberculosis in Colorado and the United States is apparent, and we are honored to have him with us today.
That's quite the introduction. I appreciate that. I'm Bob. Keep it simple. I am the medical director for the Denver Metro Tuberculosis Program, and appreciate you all coming out to and inviting me up to talk a little bit about tuberculosis, a really old disease that we do have a few new tricks for, and I'm going to go through some of those with you today. I don't have any conflicts of interest. I am going to be talking a bit about an off-label use for nucleic acid amplification tests, so PCR tests. They're approved for respiratory specimens only in the U.S., but they actually have a role in non-pulmonary specimens as well. In terms of the objectives, my hope is that after we go through this, you'll be comfortable recognizing the different ways that patients will present with active tuberculosis, be able to explain the role of different tests for diagnosing TB, and then describing the steps for preventing active TB in a patient. If they're not already, these slides will be available for you all as well. So anything I have, you guys are more than welcome to. So I'll start with a case example, and I've got case examples throughout this, and these are patients from really from around Colorado. We have the opportunity at the Denver TB program to consult with the state, so we sort of know about or help with patients from around Colorado. And this was a 52-year-old male. He was originally born in the Pacific Islands and had some travel for the U.S. military, but had been in the lower 48 for most of his life. He was known to have a positive skin test, but also had been vaccinated with BCG as a child. And he presented to the emergency department with 1 month of cough, fever, and weight loss. And he had this chest x-ray, and it was appropriately recognized as abnormal. He had bilateral nodular opacities, and they wanted to admit him to the hospital, and he said no. And so he was allowed to leave. He was prescribed azithromycin for atypical pneumonia, and it didn't work. And he came back 2 weeks later, and he got hospitalized then. And in the hospital, he got a quantiferon blood test. That was negative. He got a bronchoscopy and had a lung biopsy, and the biopsy came back granulomas, non-necrotizing, AFB smear negative. So what do you think happened? What did they diagnose him with? Either hypersensitivity, pneumonitis, or sarcoidosis based on that. And how do you treat either of those things? High-dose steroids. So they put him on high-dose steroids, and what do you think happened? He got better. He got better until he didn't. So high-dose steroids made his fevers go away, improved his appetite. He got discharged from the hospital, and a month later he came back into the same hospital X-ray much worse. CAT scan showed his lungs were destroyed. And he died about I think it was either on or a day after his 53rd birthday from tuberculosis. And so it's a dramatic case, and I put it at the beginning to demonstrate some of the challenges that we have. He underwent a workup. Somebody thought enough about TB to get a quantiferon and to send his biopsy for AFB smears. Both of those were negative and failed to diagnose it. So before we get to some of the tests and the options we have available, I'll take a step back and talk a little bit about the epidemiology. So TB, while it's relatively uncommon in the US and relatively uncommon in Colorado, this is active tuberculosis, it's a very common disease globally. It's estimated 1.8 million deaths, making it the leading infectious disease killer in the world. TB kills more people than HIV every year. In Colorado, you can see our cases declined from the early 2000s until the recent years, and we've been fairly flat for the last 5 to 7 years. 60 to 70 patients diagnosed with active TB every year, and that number really hasn't been changing. I think we're probably going to be up in 2017. It looks like in terms of total number of cases. Importantly, in 2016, we had 11 deaths related to tuberculosis. 3 of them were patients who were diagnosed post-mortem. So tests were sent, the patient died, and then subsequently a culture came back that diagnosed that person with TB. 3 were alive but died from their tuberculosis. And then the other 5, it was other complications that the TB contributed to but wasn't the direct cause of death. 11 deaths in our 73 patients. So the first step in all of this at any point in time is thinking about TB. So the misses that happen oftentimes are people not thinking about tuberculosis as a possibility. And we break that down into kind of 3 areas that we ask people to think about. Think about risks for infection. Think about risk for progression. So if you get infected, not everyone's going to get sick with it, but there are risks that will make it more likely for someone to get sick. And then thinking about symptoms that can be the signal that someone might have active tuberculosis. The risk for infection, it turns out, boils down to essentially you've got to be around someone who has TB and has pulmonary TB to catch it. And so knowing where TB is common. So this is a map from the World Health Organization, and this was updated in 2015, estimated rates from 2015 from the 2016 Global Health Report. And you can see the areas with the highest incidence are the areas where TB and HIV interact. So sub-Saharan Africa has the highest incidence, total cases per 100,000. The countries with the most TB are the countries with the most people. So India and China have the most absolute number of TB cases. In this sort of diagram from the World Health Organization, you see that the US and Mexico are shaded the same. And so that's based on the cutoff they use. The incidence of TB in Mexico is about 3 to 4 times what it is in the US. So it is still much higher. And it turns out in Colorado and in many parts of the US, more patients with active tuberculosis come from Mexico than any other single country. And that just has to do with the numbers of people and the proximity. So more people are able to travel back and forth from Mexico than from South Africa. And so we see lots of folks who have tuberculosis, their risk factor is having lived, traveled, or being born in Mexico. That's the risk for infection, basically. You got to be around someone. There's some minor other risks, like unpasteurized milk and cheese products. You can actually get a form of tuberculosis from those things called Mycobacterium bovis. So that's a great point. So the point was that within the United States, even there's a real difference in terms of risk, and so the Sioux Nation or the Indian nations in general have a higher risk of TB overall. There are some areas of the country where homeless populations have a higher risk. It's actually not that great a risk within Colorado. The people experiencing homelessness in Colorado, generally, we screen actively, and so the rate of TB is fairly low there. A lot of it depends on where people are and where people travel to. So within our low incidence state, the 60 or 70 people diagnosed with active TB will come from 30 different countries. And so we really see a global snapshot of TB within Colorado. And that includes US-born persons who travel. So, there are plenty of us, people in healthcare, who go and work and volunteer or spend time in countries where TB is common, either following natural disasters or volunteering through church groups or other things. We do this type. So I spent 2 weeks this summer volunteering at a hospital through the University of Colorado, actually, at a hospital in Zimbabwe. So that's a greater risk to me than the 50 weeks I spend working in the TB clinic in Denver was the time I spent there. And so thinking about those, thinking about where people go, asking them about travel, and it may be travel 10, 20, 30 years ago. That's the other trick with TB. Is if you can be infected with it, and if you've never been tested, you can carry that infection for decades. And so, every year we're diagnosing people in their 80s and 90s who have never lived outside or traveled outside of the United States, and they almost certainly were infected long ago. And oftentimes they may know a relative who had TB when they were a kid, and they've probably carried that infection their entire lives, and they lived long enough for their immune system to get a little weaker, and the TB reactivates. So that's essentially it for how you get infected. You got to be around someone. But most people, as I said, won't get sick. It's about roughly 10% of people who get infected will get sick. There are conditions that increase that, HIV being the one most commonly associated with it, although the one that's taking over globally is diabetes. So, there's a global epidemic of diabetes. It's linked to lots of things, including obesity. And diabetes is projected to be more commonly associated with TB than HIV within the next 5 to 10 years. And so patients with diabetes are at much higher risk than someone without diabetes, about twice the risk for reactivating. Chronic renal failure is another risk. Often chronic renal failure and diabetes are tied together. And then there's a number of things that immunosuppression, TNF-alpha inhibitors and other medications, biologics that we're using more and more commonly for autoimmune diseases and other conditions increase risk. So all of those commercials that we see on television, what do they all say? Make sure you get tested for tuberculosis. And everyone in the country just about has heard about tuberculosis through some commercial for some agent that's supposed to be some rare disease anymore. I saw the one for lung cancer. I still can't figure that out, that there's a chemotherapy for lung cancer, like a small cell lung cancer being advertised on television. I don't understand that, but so those are the main risks for progression. So you got to be around someone to get infected. If you get infected, if you have one of those risk factors, you're more likely. Still, most people we see who get sick with TB don't have one of those risk factors. So you can't exclude based upon that alone. So what are the symptoms? So the classic symptoms, right, that we learn from medical school and beyond is cough, shortness of breath, hemoptysis, fever, night sweats, weight loss. And the number of people that present to me with all of those symptoms, or even some constellation of 3 or 4 of those, is pretty low. And so you can see, and I've shown the relative proportions for HIV infected versus uninfected. And so you can see dyspnea, fever, fairly common, but not near 100%. The sweats, the weight loss, it's generally an indolent and subacute chronic type of an illness. People don't often present acutely sick. So again, these are the classics that people look for. Now, I'll tell you, most people who have a cough more than 3 weeks in Colorado don't have tuberculosis, right? They have a post-viral whatever, little reactive airways disease, something, and they feel fine. So it's not just having a cough, but if you have a cough and you're having other symptoms, if that cough is getting worse and you're having fevers or you're having unintentional weight loss or night sweats. Same thing with hemoptysis. Most hemoptysis in Colorado is probably bronchitis. But if you have hemoptysis and you have other things, those are the sort of typical symptoms for tuberculosis. But TB presents in lots of different ways. So recurrent pneumonias and recurrent urinary tract infections, you want to think about and wonder about tuberculosis. One of the reasons this occurs is because common treatments for pneumonias and for urinary tract infections are fluoroquinolones. And fluoroquinolones have tremendous activity against TB. So levofloxacin, moxifloxacin will make people much, much better. X-rays will get better, symptoms will get better with even a short course, 5 days. But like any single drug, it won't cure TB. And so people get sick, they get treated, they get sick, they get treated. And we've seen folks go for a year or more with recurrent infections before getting diagnosed. Effusions, pleural effusions, pericardial effusions, peritoneal effusions, adenopathy, so usually cervical more than anywhere else, but swollen lymph nodes anywhere, subacute meningitis, pathological fractures, and actually infertility. So TB is the leading cause globally of infertility. And in our low incidence state, we generally have 1 or 2 women every year who's undergoing a workup for infertility, gets an endometrial biopsy, and it comes back granulomas, and it's tuberculosis. And so, not commonly thought of, but turns out to be a common disease. And so, just a breakdown of what we see, about 2/3 of the people diagnosed with TB in Colorado will have pulmonary disease, and the other third will have TB somewhere else. And this could be in the eye, in the skin, in the bone, in the kidneys. We see TB almost everywhere. So this is not difficult. 41-year-old guy comes to the hospital with several months of cough, dyspnea on exertion, known positive skin test, never been treated. He's got infiltrates throughout. He's got volume loss and destruction and cavitation. It's been going on a long time. He's even got areas of calcification in his pleura. That's not a difficult one for someone to make for TB to enter the consciousness and for someone to make the diagnosis. This one was a little more difficult. This was a 36-year-old gentleman who presented to the emergency department at Denver Health with fever and abdominal pain. He was originally from Cuba. He suffered from schizophrenia, and he was homeless. And he came and he had this chest X-ray. And if you're trying to find the disease, you're not alone. He had a normal-looking X-ray, and so he was diagnosed with gastroenteritis as the cause of his abdominal pain, and sent out. And he came back just about 6 weeks later, and he got another film. And it's a little hard to see on the projection here that it's changed, but if you can get even a sense that the film in August is just a little fuzzier than the one in June, I'll show you his CAT scan. So his CAT scan was classic miliary tuberculosis. So he had these tiny little dots all throughout his lung when he returned that weren't there when he originally presented. And his abdominal pain, the reason he originally came in, was significant lymphadenopathy around his aorta. And so someone presents like this. What do you think the chances that you're going to get a sputum, right? That's our first step generally is we get a sputum smear. What's the likelihood that he has a positive smear with this extensive disease? So he has disseminated tuberculosis, both lungs throughout, and adenopathy. You think it's 75, 50, 25? How many for 75? 50? 25? More for 25? Yeah, it's low. It really is low. And the reason is the TB bugs are not in the airways. They're in the interstitium of the lung. So cavitary disease is more likely smear positive. Non-cavitary disease, even if it's extensive, much more likely to be smear negative. Good. So the question was, did he get a CT originally when he went in for the abdominal pain? He did not. He got some labs. His labs were relatively normal. He got the chest, he actually got like an abdominal series, plain films as well, demonstrated that he wasn't obstructed or anything. And so he was sort of sent out with relatively normal looking labs and films, but no CAT scan. Yeah. This is an example of lymphatic tuberculosis. This is a dramatic example. This is actually on treatment. Usually these present as cold and large lymph nodes that unless someone is thinking tuberculosis, the immediate concern is cancer and often lymphoma. And so these get taken out and thrown in formalin and sent to pathologies, and then they come back granulomas. And then typically when we start treatment, the lymph nodes will get worse. And so we always warn people, once we start killing the TB bugs, because when they're alive, they're adept at hiding from our immune system. Once we start killing them, then our immune system overreacts. And so before HIV, before we knew anything about immune reconstitution, when you treat HIV, we knew about paradoxical reactions with TB. You start treating TB, and the symptoms and the signs can actually get worse. And that's what this was. This was on treatment, and we drained it off. And I think the record was Bill Berman, who ended up aspirating over 100 times someone who had lymphatic TB, and it just kept coming back and coming back. And he aspirated, and eventually it went away. And these do get better with time. Our colleagues in ENT have there's a myth that operating on these or draining these will lead to chronic draining sinus fistulas, and it's not true. They actually don't do that. And in fact, if you don't drain them, they'll often drain spontaneously. And if you treat the TB, they eventually heal. This was an 80-year-old woman who underwent surgery and had an epicardial pacer placed, and she developed a postoperative infection from this epicardial placement. And when they went in and they drained it, it was all tuberculosis. So we see TB reactivating in areas of surgery at time. This was the most dramatic case of Pott's disease I've ever seen. So this an older woman from India who had come to the U.S. to be with her family later in life, and she had this deformity for years and years, and it was sort of old, burned out Pott's disease. This guy had calcified lesions in the upper lobes of his lungs, but where the active TB was currently was actually in his shoulder. And so he presented with a draining sinus from his shoulder that grew Staph aureus, but the pathology was necrotizing granulomas. And the surgeons had, I don't know if they were thinking of it, but they had sent AFB and fungal and other cultures, and sure enough, in addition to the staph that was probably a secondary infection, he had TB in his shoulder. And this is an example of TB in the brain, so a tuberculoma, so presenting as a mass lesion in the brain. And in this case, it was a patient who had HIV. So one of the things that I always like to point out, and I like to say, and one of the reasons I like to come around, because as Dr. LaBailey said at the beginning, we really try to be available, and so the other thing you all can have is my cell phone. We want people to call us when you suspect TB, because we hope to be able to help. And one of the ways we can help is if people contact us is not everybody with suspected TB needs to be hospitalized. So we can do a lot of workups on folks outside of the hospital. We may need to isolate them at home, so we may prevent people from going to school or from work or other things, but not everybody needs to be admitted or needs to be kept in the hospital. If you do put someone in the hospital and you're collecting sputums on them, you all may know this, but it doesn't always get translated to the nursing staff or to others, is the patients don't need to wear a mask in that negative pressure room. Sometimes that happens. People make the patient who's in the negative pressure room wear a mask, and that's not necessary. So you don't want to do that. And when they're leaving, if they need to go out for procedures and things, they don't need the N95. So a simple surgical mask for someone you suspect has TB. The N95 is to protect all of us so that any little TB bug that could be floating in the air in the room where they're spending most of their time, so that we don't get infected. But the patients don't need to wear an N95. So let's talk about diagnosis. And the CDC, IDSA, ATS published new guidelines actually in January earlier this year. And they listed 7 essential lab tests for diagnosing active TB. So the nucleic acid amplification tests, these are quick, one day. The current generation of these tests will actually give us information about drug resistance, so they're even more powerful than they used to be. Smear microscopy, still a cornerstone for us, although I envision a day in the future where the nucleic acid amplification test may entirely or mostly replace smears. Culture, which is still the gold standard for diagnosing TB. Liquid, which takes about 10 to 14 days. So if you collect a culture, you can roughly expect it's going to take 2 weeks to grow if it's TB. Or solid, which will take about a month. And then once it grows, there are probes or the high-pressure liquid chromatography that you can get in a day. And then susceptibility testing conventionally takes 2 to 4 weeks, depending on the test. So once you've thought about TB because someone has risks or they have symptoms or they've traveled, the next step is collect specimens. And usually our first step is to collect smears. And so how good are they? Well, it turns out not very. Right? Sputum smears are somewhere between 30 and 70% sensitive. So you're missing between 30 and 70% of people with pulmonary TB by looking at a smear. Lymphatic tuberculosis, it's less. Pleural, peritoneal, and CSF, it's all worse. So anything outside of the lungs, it's even worse than that. So if you're counting on a smear to make your diagnosis, there's not very good tests overall. If we look at again the guidelines, the recommendation is still to get 3 specimens. The sensitivity overall gets up to as high as 70% for pulmonary TB. The specificity is generally pretty good, over 90%, and particularly in Colorado, we don't have, relative to other parts of the country, we don't have really high rates of non-tuberculous mycobacterial infections. And so if you have a positive smear, it's generally more likely to be TB than to be MAC or some other non-TB mycobacterium. Cultures, as I mentioned, are gold standard. And so highly sensitive, highly specific. And then the nucleic acid amplification tests, the PCR tests. And these now, for the first time, are in the recommendations that they should be done on an initial respiratory specimen for everyone who is suspected to have pulmonary tuberculosis. And here's the reason why. The Gene Expert is one example of this. Do you all know? Do you all have Gene Expert here? And you have Gene Expert for TB? December 1st. There we go. You have Gene Expert for TB. So Gene Expert is a platform, actually. It's a laboratory molecular-based platform that can do testing for a lot of different things, including C. diff, including MRSA, and a variety of other infectious diseases. But tuberculosis is one of them, and one that they've really been successful globally at improving the ability for diagnosing TB in areas where they were reliant on smears, or sometimes not even that, reliant on clinical judgment alone. The Gene Expert platform has been tremendous, and it's incredibly sensitive for smear-positive disease. And so, you say this is just one example that I pulled out from that was referenced in the guidelines, and they showed, with sputum, 2 or 3 smears, your sensitivity is 60 or 70%. With a Gene Expert, for the ones that were smear positive, if you do a single Gene Expert, it's about 97% sensitive. If you do 2 Gene Experts on successive sputum, you get up to 100% sensitivity for smear positive disease. But more importantly, you also pick up 60% of those smear negative patients by doing a Gene Expert. And the specificity is quite high, really, really low false positive rates. And so a group that I'm involved with, the National TB Controllers Association, along with the American Public Health Laboratories, got together because the FDA approved this. So the FDA approved Gene Expert as a test to remove people from respiratory isolation in hospitals. But the FDA didn't give a lot of guidance. They said, yeah, 1 or 2 is good. And that's all they said. And so we got together and said, well, it's maybe a little better, a little more detail would be useful. So we organized a group and came up with an algorithm that essentially does say the same thing. We think 2 is probably better than doing a single. But if you have 2 negative Gene Expert tests, you can likely stop isolation. One of the most important things for all of the tests we do is that they're well collected. So, I mean, this is true of smears, of cultures, of anything you do. If you get spit, your yield is going to be poor. So making sure that expectorated, if someone's coughing and generating lots of sputum, great. If they aren't, then inducing a sputum, but getting a good sputum. And it's still not a replacement for culture. And so you still want to do culture. And we still do say, I mean, if you get 2 negative gene experts, but TB is the most likely thing on the list of illnesses making this person sick, you might still keep them in isolation. So it doesn't replace our clinical judgment and our thinking, but I'll tell you, for most patients, this is going to be good, and you can get these quickly. So at Denver Health, our policy is we'll collect sputum every 4 hours. So we'll end up collecting our 3 sputum within 24 hours for sure, and we're integrating this into our EPIC order set to get gene experts so that we can move more quickly to remove people from isolation who don't need to be. We'll collect 3. It usually ends up being more like 12 to 16 by the time everything, because someone goes in and puts a cup, and then if we have to induce sputums, we could, if someone was really strict, they could collect the sputum over 8 hours. And we run 2. We'll run 2 of those on Gene Expert then. And if both are negative on Gene Expert, and this algorithm does not rely on smears. So that's the other thing with the algorithm recommendation. Doesn't say you have to have smears and the negative Gene Experts. If you have 2 negative Gene Experts, because it's so sensitive for smear positive, right? It picks up 2 Gene Experts pick up 100% of smear positive, and you're going to pick up most of the smear negatives. The Gene Expert really is the, I think the preferred test, ideally.
Do they have to be 8 hours apart?
Yeah, so this is what the committee that put this together says 8 hours apart. I'll tell you, this is what's most important, to be honest with you, is it a good specimen? And the amount of time between isn't really that valuable. That 8 hours, or what used to be morning sputums, was a theoretical that was never bore out, and this was the best study. There are a number of studies that have looked at the issue of timing of sputum and also bronchoscopy. This was still the best, I think, published a decade ago in CID. I guess I referenced another more recent one, but in this study, they brought people who were suspected of having tuberculosis, and they enrolled them in a study, and they did induced sputums, and they did 3 sputums in 24 hours, and then they collected 2 additional sputums over subsequent days, so they had 3 sputums over 3 days, and then they did bronchoscopies, and in fact they did gastric aspirates. So they really did everything you could imagine. These were kind souls who agreed to do that. And what they found was that all of the patients who were smear positive by bronchoscopy were positive by the induced sputum. The bronchoscopy actually missed 2 people who were positive by sputum. So, reinforcing that you don't need to do a bronchoscopy to diagnose TB. Get the sputum. There was no difference in the yield in the ones that were collected over 3 successive days and with morning sputums versus collected the same day. And so really our approach, and what we tell our colleagues, our pulmonologists and others, is really only do the BAL if you're looking for something other than TB, or you just can't induce a sputum. And we've seen that occasionally. But otherwise, and the folks I work with, the pulmonologists I work with at Denver Health, if TB is on the list, they're like, we're not touching them until you get sputum and you're confirmed. And even sometimes then they'll say, and then put them on treatment for a month, and then if you still need a bronch, then we'll do it. So really reducing the risk to folks. It can be done safely. You mask up and you do those things. You don't want to do a bronchoscopy on someone who might have TB though if you don't need to. We use the skin test. We use our blood tests as tools for diagnosing active TB as well as latent TB. And for active TB, I think it's important to keep in mind, like that first patient I showed you, who they did a quantiferon thinking about TB and it was negative. How good are these tests? Well, the skin test misses about 30% of people with culture-proven active TB. So the skin test is not a great test. And the blood tests are better, but aren't great either. You get up, the best, you start to touch 90%, but you're going to miss 10% of people with active TB if you're relying on these tests. And so I always tell people, these can be useful adjuncts if you're trying to make a decision about, empiric treatment maybe, but they're generally not very good tests. And unfortunately, I still see people making decisions based on this in the hospital and also in the clinics, where someone comes in and they have a chronic cough and they go, gosh, I wonder about TB. And so they do one of these tests first and wait for the result before they send them for an x-ray or refer them to public health. And that's not what we want. We want, if someone has a cough and you're worried about TB, get an x-ray. If that x-ray is abnormal, or you can't get an x-ray, or there's, that's where we want to be involved, because we can help make sure those things happen. So this is another gentleman that we saw. This was a patient last year who had a known diagnosis of cryptogenic cirrhosis, and he was at Denver Health in January of last year with an upper GI bleed and had a pretty relatively normal x-ray, and then came back in May with sepsis and had a new right-sided pleural effusion. And that got tapped, and it was somewhat bloody. It was lymphocytic, had a slightly elevated LDH and total protein. He had a procalcitonin done. His procalcitonin was normal. So this gentleman came in, he got diagnosed, he got some antibiotics, he got a little bit better, he got discharged. He came back in June, still had an infusion, was treated similarly. July, still having problems with this effusion. He got retapped in July, his pleural fluid. It looked pretty similar to the numbers he had the first time. This time he had an ADA level sent. So an adenosine deaminase level that you may or may not have learned about or heard about as being a test for tuberculosis, and it came back low. And so at this point, infectious disease was consulted. They had done an echocardiogram and they saw something funny on his heart valve, and so they were convinced he had culture-negative endocarditis, and they called ID saying, we want you to treat for culture-negative endocarditis. And he happened to be my colleague in the TB clinic, Dr. Michelle Haas, who was doing our inpatient consult service, and she recognized that this gentleman was born outside the US and was therefore at risk for TB and hadn't been worked up. And so she said, yeah, he could have culture-negative endocarditis, but first let's get some sputum. And sure enough, he was smear positive, gene expert positive, and this was all TB. And so what about these ADA levels? So ADA and in fact something called free interferon gamma levels are in the guidelines that were published in January of 2017. I did a little evaluation because I'd actually never heard of anyone sending this. It's because it's not approved. And the reason they put it in the guidelines, because I asked Dave Lewinson, who was the lead author, like, why did you put this in? No one can get it. And he said, yeah, but it takes so long to revise guidelines, we figured it might become available in the next decade. And so we put it in there just in case. So that's why. So if you pull out these guidelines, that's where that is, but don't try to order it. But the ADA is there, and they list, and this is, I pulled this from a number of their references. It talks about different sensitivities and specificities. And so they include it, and they recommend getting it for pleural, meningeal, peritoneal, or pericardial TB when it's suspected. And their rationale for it was to saying that if the sensitivity is at least 70% or greater, and if the specificity is 80%, then it may be beneficial, so we recommended it. And I said, that's fine, except my problem with the ADA, as in the case I showed you, is that it's not a great test. It's a send-out. I don't know of anyone that does, hospitals in Colorado that do it in-house. So the turnaround time is measured in days, which is, in hospital medicine is an eternity. It doesn't replace the need to get tissue. So if you suspect not meningeal, but pleural, peritoneal, pericardial, the best source for diagnosis is getting a biopsy, getting tissue, because that you get pathology, you get the ability to do cultures. And so I think the role in the U.S. in high resource settings is essentially zero. I don't recommend ADA levels because it's not 95 to 100% sensitive. It's not that specific. And I think I've seen it too often than not lead people in the wrong direction. So in the case here, so the ID consultant didn't recommend the ADA. So the infectious disease, we weren't involved until after all of this was back, and it was the third hospitalization for what was at this point a chronic pleural effusion that was, lymphocytic, somewhat hemorrhagic chronic effusion in a gentleman with cryptogenic cirrhosis, and said, all right, TB. Now, in some ways, we got a little bit lucky that it was smear positive, because this would have been a tough one to biopsy because of the liver disease. He had a coagulopathy. It would have been challenging, and treatment was challenging because our medications are generally carry risk for hepatotoxicity. So treatment for him was challenging as well. But yeah, we don't. When we suspect TB, I don't recommend an ADA level. The only scenario where I would consider it is a scenario where I couldn't get a biopsy for one reason or another, and where the treatment was going to be so risky. So this is one where if we had negative workup, we had negative sputums, where we would have been a little bit stuck. We would have said, here's a guy that doing a pleural biopsy is going to be really risky in, because he could bleed, he could have complications of bleeding. Empiric TB treatment is really risky because he already has liver disease, and the medications I'm going to want to use could tip him into decompensated liver failure. So this is a case where I might have thought about using the ADA level, and it would have failed me, turns out. So, but this is essentially the scenario where if we were really stuck, we might try to rely on these indirect tests that frankly aren't very good. Great question. The question was, what was the source for the gene export? It was on the sputum. So it was not on the pleural fluid. So the pleural fluid was never sent for AFB when it was tapped. Once we had this, we didn't go ahead and send it, but it could have been. Again, it's not approved, but there are labs that can validate it internally, and there are labs that will do gene export or another PCR-based test on pleural fluid, on meningeal fluid, on pericardial, peritoneal. You can get these, and I've got a slide. I'll just show. I'll finish. Done railing against ADAs. So diagnosing extrapulmonary, the histology is generally key, and it's the histology that also leads to our yield on culture. So the fluids, the guidelines quote a smear positive spinal fluid of 10 to 30%. I've never seen this. I think this is based on literature in high burden countries that see a lot more late meningeal TB. I've never seen anyone with a positive smear. But the culture yield is improved by getting histology. But gene experts, it turns out, are quite good for all forms of extrapulmonary TB, as you just expect, right? I mean, PCRs are replacing our traditional test for lots of things. We're doing it for workups of diarrhea, workup of viral respiratory illnesses. We need to get to a point where we're doing it more routinely for TB. So this was a young man, 29-year-old, originally from Chicago, no past medical history. In late July last year, he developed fevers and a headache. In early August, he went to an urgent care center and was given doxycycline for presumed pneumonia. No x-ray was done. In late August, he went to an emergency department because he wasn't better, and he was diagnosed with pneumonia and given a prescription for levofloxacin. In mid-September, he saw a pulmonologist as an outpatient and underwent a bronchoscopy and a biopsy. The BAL cultures were sent for AFB and were negative. The biopsy itself was non-diagnostic. Essentially, there was no abnormal tissue in the biopsy. He woke up later in September, about a week to 2 weeks after he saw the pulmonologist. He woke up confused, and his fiancée took him to a hospital. His white count was normal, his basic metabolic panel was normal, his HIV was negative, his SED rate and his CRP were normal. His spinal fluid was abnormal, it was mostly neutrophilic, elevated protein, low glucose, and he got started on what you would start him on for meningitis, so ceftriaxone, vancomycin, acyclovir. He got dexamethasone as part of that, sort of the pneumococcus, although this was really not an acute illness. This was September, his illness started in July. And he initially got better, And then the steroids were stopped when the workup was negative, and then he got worse again. And he had an extensive workup for bacterial, viral. He had syphilis. He had lots of PCRs sent, pneumococcal Legionella antigens, histo and cocci, viral panel, Lyme antibodies. He had quantiferon TB Gold. All of these tests were negative, including the quantiferon TB Gold. He got progressively worse, and despite broad empiric treatment, he started having strokes, and he died in early October. About 2 weeks later, a bronchoscopy that he had in the hospital and his spinal fluid that was collected grew TB. And that's when we got notified. And so despite having an upper lobe infiltrate, despite having a lymphocytic subacute meningitis, despite thinking about TB, the providers, and I know all of them well, excellent physicians, never got to a point of thinking about tuberculosis to contacting us or thinking about empiric treatment. He got empiric treatment for everything else. He got antifungal treatment. He got everything else besides tuberculosis. And so when we talk about TB treatment, there's two reasons we do empiric treatment. So this is treatment before we have a confirmed diagnosis. We do it for life-threatening conditions, and TB meningitis is as bad as it gets when it comes to TB, and is a tough one to confirm. Less than half of TB meningitis do we actually get a culture confirmation. And so most of what we're doing, if we're successful, is actually empiric. And then we do empiric treatment for public health reasons. So we do it so that people can return to school or work or being in a congregate setting without that risk of TB transmission. And so again, these are not decisions that we want or necessarily expect people to be comfortable making on their own, because you're not going to see a lot of TB. So that's again where contacting us if you suspect TB and letting us help with this. Because the other thing we help with is the directly observed therapy. So directly observed therapy is a state requirement for anyone with pulmonary TB, and we do it for everyone. We do it for everyone because the medication stinks, it's hard to take, it makes people feel sick, and nobody does it correctly because of that. It's too many pills, and unfortunately our TB treatment hasn't improved over the last 50 years. The last medication in the standard regimen was discovered in the 1960s. And we haven't had any real major advances since then. So rifampin in the 60s, INH, PZ-ethambutol earlier than that. And I've listed the main side effects, not for anyone to memorize necessarily. The big one with rifampin is drug interactions. INH and PZA, more than rifampin, are the liver toxicity. And ethambutol, very rarely, optic neuritis. Treatment is the 4 drugs daily for 2 months. Usually the first 2 to 3 weeks, if it's pulmonary TB, the person is on home isolation. And then after that, they're able to safely return. And then the continuation phase is INH and rifampin for 4 months. So if everything goes perfectly, 6 months to cure TB. So the last thing I'm going to touch on was prevention. Because TB is largely a preventable disease, because most people who get infected with it don't get sick right away and carry the infection for many years. So that gives us a window of opportunity to treat those people so they don't ever get sick. And we know that it works. So latent TB infection is incredibly common. Between 6 and 13 million people are infected, and that's a pretty big range, and that's because our tests are imperfect. So this is based on skin tests and blood tests, or the combination of the two that gets you that range. The greatest risk factor is living somewhere where TB is common. So people who are foreign-born from a country where TB is more common are more likely to be infected than someone who's born in the U.S. and hasn't traveled or left. The U.S. Preventive Services Task Force in 2016 actually came out with a recommendation in favor of screening patients for latent tuberculosis infection. And they say populations at risk. And again, at risk in the U.S. and in Colorado is mostly living or traveling somewhere where TB is common. So if you do that and you screen someone, it's important to always rule out, even if they're asymptomatic. So everybody gets a chest x-ray. If the chest x-ray is abnormal, even if they're asymptomatic, we collect sputums. And we diagnose, so, it's somewhere between 1 and 5% of those people will have active TB with no symptoms and an abnormal chest x-ray. So it's not a lot, but it's enough that we don't want to be treating those people with a single drug and developing drug resistance. Question?
When you say abnormal chest x-ray,
Yeah.
upper lobe infiltrates, or do you mean any abnormality
Great question. So what do I mean by abnormal chest x-ray? So I mean infiltrate anywhere or even like a lung nodule. What I don't mean is granulomas. If someone has a 3 millimeter nodule, which is a typical size of a granuloma, then you don't need to get sputum. If they have some isolated pleural thickening, so a little bit of pleural capping we sometimes see in patients with TB infection, or a little bit of blunting at the angle, you don't need to get sputum. But almost anything else, we've seen isolated lung nodules, 1 centimeter lung nodules in asymptomatic patients, it's TB. We have a patient right now who had a spiculated lung nodule 3 years ago, went in for a wedge resection. The surgery was complicated and ended up with a pneumonectomy. Pathology came back necrotizing granulomas. Unfortunately, they thought, well, we cut it out, we're done. And so they didn't do anything about the necrotizing granulomas from the lung. 3 years later, she comes back and now has a bronchopleural fistula and a complex empyema, and it's all tuberculosis. And so now she has an LOSer, which is where they take the ribs and they internalize and they open up a hole to the chest cavity so you can pack it, and it drains continuously for TB in her lung that was worked up as lung cancer. And so almost any abnormality, we have a very low threshold to get sputum on folks. Now those people, if the smears are negative and they're asymptomatic, they can work, right? We don't keep people restricted who have no symptoms and have negative smears. We don't keep all of those folks, out of the community until proven otherwise, because most of them won't have TB, but we will find folks that have it. It's always important if you're thinking about starting someone on TB treatment to ask them if they've ever taken it before, and then looking at the risks of toxicity. There is a helpful online tool that can help for calculating someone's risk of TB reactivation. So it's a free tool, the tstin3d.com. So you can punch in someone's information and it'll spit out to you what is their risk of reactivation tuberculosis, their lifetime risk up to the age of 80. In terms of treatment, we generally are recommending rifampin over INH. We've been using this now actually for a long time. 7 or 8 years is our preferred regimen because it's shorter, it's better tolerated, and people will finish it. And so INH rifapentine, we actually are using increasingly. So INH and rifapentine once a week for 12 weeks is a safe and effective regimen. It was originally studied and recommended directly observed therapy. Just a week ago, we had publications in the Annals of Internal Medicine showing that adherence with self-administered once-weekly treatment is acceptable. It's better if we watch them, but we can't watch everyone take medicine, especially for something like latent TB. So self-administered therapy is acceptable as well. So I'll stop there. We've got the summary that, again, you all can have these slides, and we'll see if there's any questions. Great. So how do you sell it, right? That's kind of the question is, how do you convince someone who feels well and you're telling them they have this infection and they have some risk of getting sick with it, but like how do you communicate that and convince the patient? So the way I do it is I try to put it characterize it into something that they might have a better concept about. And I'll talk to them about something like cancer. Say, listen, because tuberculosis is a bad disease, it kills a lot of people and it's contagious, right? So if you had, let's say, a 1 in 10, 1 in 20 chance of getting cancer in your lifetime, that you could take a medication for 3 to 9 months, depending on the regimen, that it would reduce your risk by about 90%. So it'll take it from 5 to 10% down to less than 1% if you take the medicine. So the medication works that well. Most people would do it. Most people would say, gosh, that's not that big a deal to reduce my risk of getting this bad disease that much. There's no test that can tell you that you're done, that we've cured it. So that risk will always exist, but you've significantly reduced that risk. And it usually... and usually less, I'll tell them it takes it down to less than 1%. And depending on their risk factors, and that's where that calculator I think is also helpful. So if someone smokes or has diabetes or has some abnormality on their x-ray, all of that can go into there and it'll tell you what their lifetime risk is. And so you may be 15% lifetime risk or 20% lifetime risk of reactivation TB. And so if you put a number like that on it, I think it helps people process that concept of preventive medicine as opposed to treating an illness. Right. So the question is if someone has it and you treat it, are they at risk to get it again? And how would you know it? And so yes. So it is possible to get reinfected with TB. For people living in the U.S., the likelihood of getting re-exposed and reinfected is incredibly low. Even if someone, say, is foreign-born and they travel back, they've got family wherever, if you diagnose them with latent TB now and treat them, the likelihood that they're going to get re-exposed and reinfected by traveling back for a week or a month or even is relatively low. Probably less than the risk that they would just progress from having an infection currently. And so I think that we treat people, it's true, we don't have any way of knowing if someone gets reinfected. We don't have any tests. And so we don't generally retreat people unless there's a known high-risk exposure. So if we treated someone for latent TB and now they live and someone they live with in home gets diagnosed with active TB, we might say, yeah, we should probably just retreat you. But short of that, we don't generally retreat people. Oh, good question. So the question has to do with tuberculosis in students entering universities and colleges in the state. I don't have good accurate statistics on that. It's not a requirement to test incoming students. At least in Colorado, it's not a requirement to test students, and in the U.S., it's not a national standard. We have been investigating whether or not it should be, because we do have students almost every year developing active tuberculosis at different campuses around Colorado, and that leads to big investigations and potential exposures. But no, we don't unfortunately have great numbers here. Kansas is a state that requires it, and we've been looking at how they implemented that and been talking with folks at the universities to see if we could, if we could do it voluntarily, but also could we make it a Colorado requirement for screening, but I can't give you numbers. So the question is, so if someone presents to an ambulatory clinic and for evaluation of a positive test, so in this case they mentioned a tuberculin skin test, but it could be a positive quantiferon or T-spot, do they have to be masked? Can they work? If not, what can you do to get them to work? So the first step, in terms of a mask, the mask is only necessary if they have symptoms. So the first question should be, are you having any symptoms? Do you have a cough? And if they do, put a mask on them. And that's generally a good idea regardless of if they turn out to have TB. But you don't need to mask someone who has a positive test and is asymptomatic. You do need to get a chest x-ray on them. So they need an x-ray even if they have no symptoms, because early tuberculosis can be asymptomatic. And we want to pick it up when it's early, because that's before that person is particularly sick and before they're likely contagious to others. So they need an x-ray. And if they've got no symptoms and they've got a normal x-ray, then they're cleared to work. Now, you want to consider treating them for TB infection so that they don't ever get sick with TB. But having TB infection and not having symptoms is not a risk to anyone else, so that's safe. On a related note, I'll just mention, because this comes up not infrequently when a patient gets diagnosed with TB and maybe they weren't in respiratory isolation, and healthcare workers who cared for them get really, really concerned. Am I safe to be around? Am I safe to go home? I've got young kids at home. Or if it's a woman who's pregnant, what does this mean to me? And the answer is, one, yes, it's safe to go home. So even if a person were unlucky enough to get exposed and get infected with tuberculosis, you can't give it to others unless you yourself are sick. It's really uncommon for people to progress really quickly to illness within, it doesn't happen within days, weeks. Some people can get sick within months after the initial exposure. But that in and of itself is really uncommon. And mostly the exposures that we get in healthcare in the U.S. are so minimal that the likelihood of us even getting infected is extremely low. And I work in a TB clinic myself, and the staff I supervise, we see people with active TB continuously. We haven't had anyone convert or convert by any test or become positive, in over 20 years. And so it really is not that easy to get TB. You generally have to spend many hours around someone. All right. Well, I appreciate the time. Thanks for coming out. Yeah, give me a call if you guys have any questions. Thanks.